Welcome to the Deep Dive. Today, we're going to dig into a topic that's just so vital for all of you heading into nursing, depressive disorders.
Absolutely. It's a big topic, we know.
Yeah, it can feel kind of overwhelming, right? So our plan today is to really pull out the most crucial bits you need for your practice.
Exactly. We want to give you a solid foundation. We're using notes from Chapter 25, Davis Advantage for Psychiatric Mental Health Nursing, the 10th edition.
Townsend and Morgan, great resource.
Uh-huh.
So our mission,
Yeah.
to help you get a real handle on the pathophysiology, signs, symptoms, and especially the nursing care interventions, treatments. We'll connect it all back to your role.
Let's do it. Where should we start? Maybe just defining depression itself.
Good idea. So what is depression at its core?
Well, fundamentally, it's about an altered mood. We're talking sadness, despair, pessimism, but it's more than just feeling down for a bit. It's persistent.
And it's not just feelings, right? There are physical things too.
Oh, definitely. Somatic changes like problems with sleep or appetite, and cognitive changes too. Trouble concentrating is a big one.
Okay. And you mentioned mood. I know in nursing assessment, distinguishing between mood and affect is important. Can you unpack that a little?
Yeah, that's key. Mood is the internal feeling state, kind of the emotional climate someone lives in day to day. It's sustained.
Right.
Affect, though, that's the outward expression, what we can actually see. Like someone might say they feel terrible, but their face is, completely flat, no expression.
Ah, okay. So observing that difference is a real clue for us.
A huge clue. It tells you a lot about what might be going on internally versus what they're showing.
Got it. Okay, so let's talk about the different types. The notes mentioned several. Major depressive disorder, MDD, that's probably the one people hear about most.
It is MDD. The main criteria are having a depressed mood or losing interest or pleasure in pretty much everything
For how long?
for at least 2 weeks straight. And importantly, no history of mania. That's key.
And it's not all the same level of severity, is it?
Not at all. It ranges mild, moderate, severe. And there are specifiers too, like psychotic features or if it follows a seasonal pattern, SAD.
Right, seasonal affective disorder. Okay. What about persistent depressive disorder? Dysthymia.
Yeah, PDD or dysthymia. Think chronic, but maybe less intense day to day than MDD. The mood is down more often than not for at least 2 years in adults.
2 years. Wow.
Yeah, or 1 year for kids and teens. It's that long duration that really defines it. Even if it's milder, it really wears people down. We also look at early onset, before 21 versus late onset.
Okay, so duration is the big differentiator there.
Right.
And there's PMDD.
Premenstrual dysphoric disorder. This one's tied directly to the menstrual cycle.
So symptoms flare up before the period.
Exactly. Usually the week before. We're talking depressed, mood, anxiety, mood swings, irritability. And then it gets better pretty quickly once menstruation starts. Understanding that pattern is vital.
Makes sense. And then we have depression linked to substances or medical issues.
Yes, super important for nurses. Substance or medication-induced depressive disorder. This is where the depression seems directly caused by using or withdrawing from a substance.
Like alcohol or certain meds.
Yeah, alcohol, sedatives, tranquilizers. Even things like corticosteroids or anticholinergics can trigger it in some people. It really highlights why a detailed med history is non-negotiable.
Absolutely.
And similarly, you have depressive disorder due to another medical condition, like after a stroke or with Parkinson's disease or hypothyroidism. The depression is physiologically linked to the illness itself.
It really drives home how connected mind and body are. We can't separate them.
Never. Always need that holistic view.
Okay, so thinking about why someone might develop depression, what are the predisposing factors? Let's start with biology.
Right. Biology, a big area is neurotransmitters. The brain's chemical messengers, deficits in norepinephrine, serotonin, and dopamine are strongly implicated.
How so? Like, what do they normally do?
Well, they help regulate mood, sleep, appetite, energy. So if the balance is off or they aren't communicating effectively between nerve cells, it can contribute to depressive symptoms. It's why many medications target these systems.
Okay. And hormones, too.
Definitely. Hormonal issues can play a role. Think about high cortisol levels, the stress hormone, or problems with thyroid hormones like TSH. Those imbalances are sometimes linked to depression.
And genetics. Does it run in families?
There seems to be a genetic component, yes. A family history does increase the risk, though it doesn't guarantee someone will develop depression. It's a vulnerability factor.
Okay, so that's the biological side. What about psychosocial factors? Life experiences.
Huge impact there. Things like significant loss, grief is a natural response, but it can sometimes evolve into depression, trauma, abuse, neglect. Those are major risk factors.
And what about thought patterns? I remember reading about Beck's theory.
Yes, Beck's cognitive triad. The idea is that depression is fueled by negative views of oneself, the world, and the future. And also, the concept of learned helplessness, feeling powerless after repeated negative experiences. These psychological factors are really significant.
So it's rarely just one thing, is it?
Almost never. That's the transactional model. It suggests depression usually comes from this complex interplay of this transaction between someone's biological makeup, their psychological patterns, and their life situation or stressors.
It's a combination.
Exactly. Which is why our approach as nurses has to consider all those angles.
Makes total sense.
Yeah.
Now, how does this look different depending on age? Kids versus teens versus older adults?
Great question. It varies quite a bit. In kids, you might not see classic sadness. It could be irritability, acting out, maybe physical complaints like stomach aches.
So not always obvious.
Not always. In adolescence, watch for big shifts in behavior, withdrawal, maybe increased substance use. That can mask depression. And the suicide risk is unfortunately higher in this group, so screening is critical.
And older adults. You hear about it being missed sometimes.
Yeah, it often gets missed or misdiagnosed. They might focus on physical symptoms, pain, fatigue, or it can look like cognitive decline, almost like dementia, sometimes called pseudodementia. So a really thorough assessment is crucial to tease things apart.
What about postpartum depression?
Ah, yes. PPD, it's common and can range from mild to severe. We always need to assess for the risk of postpartum psychosis. Though rare, it's an emergency.
And there's that specific IV medication now, right?
Yes, Brexanolone, brand name Zulresso. It's an IV infusion specifically for postpartum depression. Requires close monitoring in a healthcare setting, but it's an important option.
Good to know. Okay, so as nurses on the floor or in the clinic, what are we actually seeing? Let's walk through the clinical picture, maybe from mild to severe.
Okay. We can think about it across different domains. Affective feelings, behavioral, cognitive thoughts, and physiological. So, transient sadness, like the blues. Affectively, maybe some tearfulness. Behaviorally, maybe a little tired. Cognitively, nothing major. Physiologically, maybe slight fatigue. It's usually tied to something specific and passes.
Okay, then mild depression, like normal grieving.
Yeah, often linked to uncomplicated grieving or adjustment. Affectively, more sadness, maybe some anger or anxiety. Behaviorally, it could be some crying, maybe regression. Cognitively, preoccupied with the loss. Physiologically, changes in sleep or appetite might start.
And stepping up to moderate depression, dysthymia, or more severe MDD.
Here, things get more pervasive. Effectively, feeling helpless, powerless, low self-esteem is common. Behaviorally, this is where you might see psychomotor retardation, everything slows down. Or maybe poor hygiene?
Slowed speech, movement.
Exactly. Cognitively, thinking is slow, concentration is poor, maybe ruminating thoughts, and suicidal ideation becomes a bigger concern to assess for. Physiologically, sleep problems, appetite issues, fatigue are more pronounced.
And then severe depression.
At the severe end, often in MDD, effectively you might see profound despair, hopelessness, maybe a total lack of feeling, that flat effect we mentioned. Behaviorally, it can be extremes. Either psychomotor retardation that borders on stupor, or maybe agitation, significant withdrawal. Neglective hygiene
And cognitively.
could involve delusional thinking, confusion, inability to concentrate at all, maybe even hallucinations. Physiologically, significant weight changes, constipation, usually insomnia, though sometimes excessive sleep. It's a very debilitating state.
Wow. See it laid out like that really shows the progression.
Yeah.
Okay, so we suspect depression or a patient have the diagnosis. How do we apply the nursing process? Starting with assessment.
Assessment is foundational. We use standardized tools sometimes, like the Beck Depression Inventory or the Hamilton Scale, to get a baseline and track progress.
Quantify things a bit.
Right. But just as important is our clinical interview and observation, asking about mood, energy levels, sleep, appetite. Critically, always assess thought content, especially for suicidal ideation. Ask directly,
Sure.
sensitively.
Never assume. Always ask.
Always. It's our primary safety responsibility.
Okay, assessment done. Then we formulate nursing diagnoses.
Exactly, based on the data. Common ones you'll see are things like risk for suicide. That's often priority number one. Also, complicated grieving, low self-esteem, powerlessness, social isolation, maybe disturbed thought processes if psychosis is present, imbalanced nutrition, insomnia, self-care deficit.
So the diagnosis guides our focus.
It pinpoints the specific problems we need to address with our care.
And from there, we set outcomes. what we want to see happen.
Yes, patient-centered outcomes, measurable goals, like a patient will remain free from self-harm. The patient will verbalize feelings. They'll identify coping strategies. They'll participate in one group activity. Small, achievable steps.
Realistic goals.
Very important. Helps them build momentum and counter feelings of hopelessness.
Which leads us to interventions. What do we actually do as nurses?
Safety first, always. If risk is high, that might mean 1.1 observation, removing dangerous items, frequent checks. Then, therapeutic communication, being present, listening, encouraging them to talk about their feelings without judgment.
Building that trust.
Crucial. Helping them set those realistic goals we mentioned. Instilling hope, gently challenging negative self-talk, reinforcing any strengths or positive steps, no matter how small. Managing medications is a huge nursing role. Giving meds, monitoring effects and side effects, teaching the patient about them.
And basic physical care too, right?
Absolutely. Promoting sleep hygiene, encouraging adequate nutrition and fluids, assisting with personal care if needed. Don't underestimate the impact of just helping someone feel physically a bit better, and involving and educating the family is key too.
Okay, that's a great overview of the nursing process in action. What about the broader treatment picture? Psychotherapy, meds?
Both are mainstays. Psychotherapy or talk therapy is very effective. Cognitive behavioral therapy, CBT, helps change negative thinking patterns and behaviors. Interpersonal therapy, IPT, focuses on relationship issues that might be contributing to or worsened by the depression.
And the medications. This seems like a really complex area for nursing students.
It can be, but understanding the basics is essential. The main classes are SSRIs, selective serotonin reuptake inhibitors. Think fluoxetine, sertraline, very common first-line agents.
Okay.
Then SNRIs, serotonin norepinephrine reuptake inhibitors like venlafaxine, duloxetine, TCAs, tricyclic antidepressants, older class like amitriptyline, more side effects generally, and MAOIs, monoamine oxidase inhibitors like phenelzine, also older, very effective for some, but have significant dietary restrictions and drug interactions.
Right, the tyramine thing with MAOI.
Exactly. Nurses have to know about that. And critically, across all antidepressants, there's that FDA black box warning.
About increased suicide risk?
Yes, particularly in children, adolescents, and young adults, especially when starting the medication or changing the dose. We have to monitor incredibly closely for any worsening mood or emergence of suicidal thoughts.
So vigilant monitoring is key with meds.
Always. And just to circle back, we mentioned brexanolone, Zulresso, specifically for postpartum depression given via IV. That's another specific pharmacologic intervention.
Got it. Are there other treatments besides therapy and meds?
Yes. ECT, electroconvulsive therapy. It often gets a bad rap for media portrayals, but it can be highly effective, even life-saving, for severe treatment-resistant depression or depression with psychosis.
Okay.
And light therapy is the go-to for seasonal affective disorder, SAD, using a special light box to mimic natural sunlight.
This is really comprehensive. But I can see how some parts, like exactly how the neurotransmitters work or the detailed pharmacology, could feel, well, a bit much initially.
That's fair. The neurobiology is complex, no doubt. The interplay between brain chemistry and mood is fascinating, but definitely intricate. We know serotonin, norepinephrine, dopamine are key players in how brain cells communicate about mood. But the exact way it goes wrong in depression is still being fully mapped out.
Right.
Maybe we could bring in someone to simplify that a bit. Dr. Anya Sharma is fantastic at explaining neuropharmacology.
Great idea. Let's see if we can get her perspective.
Hello, happy to chime in. It's helpful to think of neurotransmitters like serotonin as messengers. They carry signals across a tiny gap, the synapse, between nerve cells.
Okay.
In depression, it's thought that maybe there isn't enough serotonin available in that gap, or the receptors aren't responding well. SSRIs, the selective serotonin reuptake inhibitors, they basically block the recycling pump.
Recycling pump.
Yeah. Normally, after serotonin delivers its message, it gets sucked back up into the cell that released it, that's reuptake. SSRIs block that process for serotonin.
Ah, so more serotonin stays in the gap.
Exactly. More stays in the synapse, available to keep stimulating the next nerve cell. It boosts the serotonin signal. SNRIs do something similar for both serotonin and norepinephrine. It's obviously more complex than that, but that's the basic idea.
That visual of blocking the recycling pump really helps clarify it. Thank you, Dr. Sharma.
My pleasure. Understanding this helps you understand why meds take time to work, the brain needs to adapt, and why monitoring side effects as the system adjusts is so important for nurses.
Thank you, Dr. Sharma. That was perfect.
You okay?
Having that basic mechanism in mind really helps connect the dots between the medication and what we hope to see in the patient.
Absolutely. It empowers our practice. Okay, so let's wrap this up. Key takeaways for our future nurses listening in.
I'd say, understand depression exists on a spectrum. Know the different types. Be aware of risk factors, biological, psychological, social. Recognize how it presents differently across the lifespan. Master that nursing process. Assess thoroughly, especially for safety.
Including that crucial suicide risk assessment.
Yes. Formulate relevant diagnoses, set realistic outcomes, and implement those key interventions: safety communication, goal setting, meds, physical care, family support.
And have a solid grasp of the treatments therapy, the main medication classes, knowing the big warnings like the black box, and other options like ECT or light therapy.
Exactly. You will encounter patients with depression no matter where you work. This knowledge is fundamental to providing truly holistic and effective care.
So here's a final thought for you to reflect on as you go forward. Given how common depression is, what challenges do you personally anticipate facing when caring for these patients in your career? And how will this deeper understanding help you meet those challenges and provide the best care possible?
Definitely something to think about. And please, if you have questions this deep dive sparked or other mental health topics you want us to tackle, let us know.
We'd love to hear from you. Thanks for joining us today on The Deep Dive.